Hello, welcome to For the Young at Heart. My name is Lucille Jerome, and I'm the Director of Social Services at Duval Senior Care in Lowell, Massachusetts. Our programs focus on the interests and the concerns of senior citizens and their families. And on today's program, we're going to take a look at Parkinson's disease. My guest is Kathy Thomas, and she's from Boston University. She's the coordinator of the APDA Information and Referral Center located at the Parkinson's Disease and Movement Disorder Clinic there at Boston University Medical Center. Boy, that's quite a moniker, isn't it? Okay. There's so much to talk about, and I know we're probably only going to touch the service in the time we have. But Parkinson's disease, I think I'm seeing more of it lately, and I guess I want to know who named it and what are the causes of it, and let's just start there and see where we go with it.
Okay, well, first of all, thank you for having me come and share the information that I have to the community. Parkinson's disease is a neurological condition. That means it is a brain condition. And although I'll talk a little bit, we've learned a lot of information to know that other systems are possibly involved.
Okay.
And it was, as you mentioned, really first described by a physician named James Parkinson. And that physician really had a number of patients that people that he wrote really exquisite monographs of their signs and symptoms. So when he first described Parkinson's disease, he described the motor problems that we most commonly think of when we think of Parkinson's disease. And what the common symptoms are, there are 4 cardinal symptoms. The first would be tremor, which is a tremor at rest, so that if you're sitting comfortably in a chair, a person may have a shaking of their hand or their leg or any of their extremities, most often the hands and legs. And what's important to know, it's typically at rest. Many people have tremor, so many people, it's a very, very common neurological symptom. Most people will have a familial or essential tremor, and if they were to pick up a cup of coffee, they would notice their tremor as they have movement. In Parkinson's, it's at rest. Another feature of Parkinson's is called bradykinesia, a long word, but it simply means slowness of movement. And when we think of individuals with Parkinson's, we know that they have a change in their speed of movement. Individuals also have a...
when you say speed of movement, you mean walking slowly? Everything is it like slow motion in a way? Okay.
Right, and it's very from person to person. Sure. If you have mild bradykinesia, it may not even be noticeable. It may, sometimes a spouse or a family member will notice that the person isn't keeping up when they're walking, or it takes sometimes twice as long to do an activity. So that is a typical symptom of Parkinson's. Individuals also have muscle stiffness or rigidity, and that is actually a stiffening of muscles. And all of the muscles in the body can be affected. The trunk muscles, the muscles when you move your arms and your legs. Like every symptom, it can be very, very mild, or it can actually be more significant.
There's a wide range, in other words,
there's a wide range.
Things that we're talking about.
Right.
Okay.
And what we'll talk about is that there are very effective treatments, or primarily medications, that will treat a lot of these symptoms. And then the fourth cardinal feature is a change in postural stability. And typically that may happen as the disease progresses. And progression can be a difficult word. In Parkinson's, it's very, very slow progression, but we do see a change in symptoms over time. Okay.
When you mentioned rigidity, we hear sometimes about something called cogwheel rigidity. Can you explain that a little bit for our audience?
Sure, and those that are watching that maybe have been examined know that the physician who works with a person with Parkinson's oftentimes will move extremities to sense how much rigidity. If you don't mind, I'll just give you a quick. So basically, you're moving, and in cogwheeling, you'll feel a ratcheting type movement, so it's not as smooth.
Okay.
And that is, for a long time, has been a way to support a diagnosis of Parkinson's disease, that type of rigidity.
So it's like, is it pulling against you somehow? Not really.
Not really. You just feel sort of not a smooth movement, and that. Okay.
You mentioned the bradykinesia. Does that affect how someone walks also? Their gait?
Yes, there can be some gait disturbances in Parkinson's, and it can be anything from sometimes when you're walking perfectly normally, you may notice your foot doesn't quite pick up in the step like it did before. So
instead of walking, what are you doing instead?
Well, either on one side or both sides, you may have a shuffle, or when you walk on a curb to step up on the sidewalk, you may not lift your foot as high. So these are just some annoyances that people can actually notice.
So there's a wide range, basically.
There's a wide range. That's right.
The diagnostic that a physician would do then might be this cogwheel?
That's one of many things. The physicians are healthcare providers that when sometimes a person may notice a change and something's happened, a family member, or if they're in for their normal health care, their primary care person may notice that some of the, not only these 4 symptoms I talked about, but there are some associated secondary symptoms, such as individuals untreated may have a change in their facial expression or masking, not smiling or blinking as often as you would see. Other symptoms that people may experience may be a change in mood, feeling depressed or feeling anxious. These are typically things that you may see very, very early on, and sometimes actually occur a long time before the diagnosis is made. So there's a whole wide range of symptoms. So when a person does come to their healthcare provider, we don't have any tests that will say you definitely have Parkinson's disease. It's really based on what the person shares with their healthcare provider and also what is observed or the physical examination.
Okay. What's the typical? Is there a typical onset for Parkinson's disease?
As far as age,
yes,
or?
Right.
Yes, the average age of onset of all the people that have Parkinson's disease, and right now 1% of the population over the age of 63 have a diagnosis of Parkinson's. The average age of onset is in the 5th decade of life, so around 57 to 63.
Okay.
However, people are diagnosed at a very young age, and I think people are familiar with people that are diagnosed in their 20s, 30s, 40s.
Well, we have a movie star, a young man who was diagnosed. His name escapes me right now, unfortunately.
Michael J. Fox.
That's right, Michael Fox.
And he was diagnosed, as you mentioned, at a young age. So about 7% of people that are living with Parkinson's have this young onset Parkinson's disease. And so they live there for many, many years with a diagnosis.
Is there a differential between men or women getting this disease?
Yes, some recent studies have shown that there's a slight predominance of more men have Parkinson's disease. And these studies have actually looked at not only gender, but race and ethnicity. And although not completely proven, a white male would have the highest incidence of getting Parkinson's, and then a Caucasian female. And there's less Parkinson's in our Black or African American population and Chinese populations.
Okay.
So that's what's known right now. But certainly everybody is at risk
Everyone's
to develop
at risk
Parkinson's.
for it. It's just interesting. I'm wondering what more research will show as to how that particular thing happens in terms of race and gender and age.
Right.
You know,
And a lot of study in that whole area.
Right. Okay. From your experience, do you see a lot of depression? I mean, I would imagine you get a diagnosis and you start to worry about your future. And would that be depression? Would that be anxiety? Would it be a combination? I mean, and then how would we help that person or these people?
Okay.
Because it sounds like there's a physical component, but then we also have our emotions to deal with.
Right, and that's very important. Depression is oftentimes under-recognized, and simply because you're dealing with a new diagnosis, maybe some changes in your ability to move about or do activities of daily living. What scientists do understand in Parkinson's disease that there's a chemical reason why patients may be depressed. Not everybody has depression, but a fair number do. An imbalance of serotonin and some of the other important neurotransmitters. I think probably the very hopeful and positive news is if depression is recognized, there are very, very good treatments, both pharmacologically, taking a medication, an antidepressant, and then really other ways to treat depression and anxiety.
Okay, so there are ways around that.
Right.
Plus family supports. And,
Absolutely.
And what are some of the treatments, now that we're moving into some of this, what are some of the treatments for Parkinson's disease? And does it would that matter based on age or gender? Would men more likely receive one type of treatment versus women because their Parkinson's are different? That was a long question, wasn't it?
That's okay. Well, actually, the answer is quite long, too, but I won't. I'll be brief as I can. The treatments that are currently available are to treat the signs and symptoms of Parkinson's disease. We are very hopeful that we will have treatments to slow the progression or modify the disease, but right now we primarily use medications, and there are several classes of medications, several different types, depending on a lot of the things that you mentioned, not specifically gender, but certainly age, when a person starts treatment, the disability that a person presents with. For example, if we have two newly diagnosed individuals and one person is a mathematics teacher who needs to do a lot of writing in a classroom, and then another person may not have to have as much fine movement. One person may start their treatment or medication earlier than the next, and there are many things to explore when you determine when a person starts treatment. So the types of medications that are available, the gold standard of treatment is a medication that's been around for many years, since the late 60s, early 70s, and it's called levodopa. It's in a formulation of carbidopa and levodopa. And that is the one that relieves symptoms the most. However, it is used carefully because the long-term use of levodopa can have some adverse effects if not used carefully. Oftentimes people are treated with other types of medication in combination, and we have medications that are very mild and are quite helpful for people that have very mild symptoms. And the type of treatment really depends on your symptoms, your health status, what you need to do, what you need to accomplish. Each medication is to change the symptoms so you can be more...
So it fine-tunes in a way.
Absolutely.
Certain medications fine-tune certain symptoms.
That's
so
right.
you might be prescribed A, if you need to do A, but something else for other activities, basically.
It is.
Okay, it's
Keeping in mind that there are some types of medications that work primarily on motor.
Sure,
And
okay.
so medication becomes a big part of a person and their family's life. And we don't just think of medication in treating Parkinson's. There are many, many other things a person, if they're not already doing, will have to do. And
Like let's go into that.
okay,
Sure.
exercise.
Exercise.
You cannot give a talk on without looking at physical activity, the extreme importance of it, and actually some of the studies ongoing now are to look at whether exercise actually can improve a person's quality of life. I think we know that that has been done, but can certainly make them feel better, move more easily. So it's very, very important.
Let's say they have this rigidity. What types of exercises would they be able to do? Like say that they are not walking as well as they used to in the past, or stand, or lose their balance. I'm going to be devil's advocate for just a minute, okay?
Okay.
So what types of exercises are there that is safe for them to do that they will feel it's okay to do? I wouldn't want anyone to be afraid to try to do something.
And very, very good point. And the good news is we have very trained individuals, physical therapists, who specialize in Parkinson's disease. Here in Massachusetts, we have several very well-trained people who work just with individuals with Parkinson's. And they, just like a neurologist would adjust medications, depending on a person's presentation, a physical therapist would also design a very important program. And then the person may work with a personal trainer or exercise specialist out in the community with a very well, carefully designed program.
When you said the average age of onset might be 57 to 63, the progression of the illness, I know you're going to say it's individualized, but what is the average lifespan? With this?
Well, the very good news is that studies have shown that a person with a diagnosis of Parkinson's really has a very close to a normal life expectancy that that person would have, certainly depending on other health issues. So that's the good news. Clearly, if you're diagnosed at a younger age with Parkinson's, you're living with Parkinson's longer. Obviously, if you're diagnosing, but we are all living so much longer.
Right.
And you had mentioned that you felt that a lot of people have.
It seems to me I'm seeing more of it. And you never know if that's your imagination or what's going on there, but you said that maybe in fact we are seeing more of it.
Well, and I think just in the last decade, I've been a nurse for 30 years, and what I've noticed is that people are living significantly longer, and our population is increasing. So therefore, we will see more people. And then thirdly, people are diagnosed much sooner than, waiting 2 to 5 years before a diagnosis is made. So awareness has helped that.
So there's the awareness, there's the diagnosis, there are multiple treatments, a wide range of treatments, it sounds like. You mentioned a few medications and how it's all individualized.
That's right.
So there are specialists specifically for Parkinson's disease, basically. That's not only in Boston.
No. There is a specialty. Typically, neurologists are trained to care for people with neurological diseases. And in their neurological training, they learn a lot about Parkinson's disease. And then within the specialty of neurology, there's also a group of physicians known as movement disorder specialists. And they primarily take care of individuals with Parkinson's as well as some of the other movement disorders. In Massachusetts, we are very fortunate. We have excellent healthcare providers across the state, not just in Boston, and very, very well trained. And it's probably because we have many training programs. One thing I do want to mention, certainly understanding the important role of the physician, but to care for individuals and families affected by Parkinson's or living for a long time, it's very multidisciplinary. You need a good team, includes rehabilitation specialists. I mentioned physical therapy, but also occupational therapy around work issues and other mobility issues. Certainly speech pathologists have a very, very important role. One symptom we did not mention, that people with Parkinson's may have difficulty with communication. Softer voices.
The voice, the volume.
Volume.
Okay, and the rate of speech. I've noticed the rate of speech. Well, that goes along with the slowness you talked about earlier.
That's right.
So the volume
absolutely.
And the rate.
So a speech and language pathologist, very, very early on, teaching exercises and mechanisms to improve communication, and also dealing if an individual has difficulty with swallowing, working with that. Social workers, very important to help not only the person affected, but their family and their whole unit, nurses.
The stressors in the family must be phenomenal once this is discovered, I would think. So that, you're right, they do need some assistance too. If, say they're diagnosed in a clinic or neurology or a neurology office or a clinic, and there's a team working together, and the family is a system, would they work together with the client? Do they all become the client, in other words, so that everyone is synchronized with what's going on? You know?
In a perfect world,
in a perfect
certainly.
world.
And that's, you know, as a nurse, that's what I always hope for, that to understand a person's whole social setting, because really the whole purpose of treatment and improving symptoms is so that we can improve quality of life. I know in our setting we work very hard to evaluate not only the person's stressors, but the families, and dealing with their sense of worry.
I would imagine that many families want to keep their loved one at home for as long as possible. What might be some of the issues that arise when a family cannot deal with this anymore? At some point, it's going to be different again. It's really individualized. Everything we're saying is individualized.
Right.
But at some point, there's a breaking point for most families, or for the person with the disease. Maybe it's a person that says, I really need to be in another setting. Is that an assisted living? Is that a nursing home? Is that some? I know with some people, they will live with one child, adult child, for maybe several months, and then with another several months, so that they rotate among family members. But how does that work out in real life?
Well, some individuals who have Parkinson's need some assistance with their mobility, if they have difficulty moving about, and also may need some care to help with activities of daily living. Depending, one thing that some people experience, you know, we have great medications to treat the symptoms of Parkinson's. Over time, for some people, they may have fluctuations in mobility, so their medicines work very, very well for a certain time of day, but then at other times they may have more immobility. That would be one reason why people may need more care. And not just with Parkinson's, but just as we age, some people need more care than others. And typically, you want your spouse to be your wife or your husband, and sometimes there's an imbalance of care, and that's when a family would seek some supportive care from, whether it's a long-term care facility, assisted living, home care. So
home care,
right,
services at home. I think when we were preparing for the program, I mentioned years ago when I was consulting at various places outside of this area, we did come across a woman, not a male, a woman, with Parkinson's, relatively advanced, but she was still able to walk periodically. And when her medication wore off, she would lose her balance and fall. And there's actually a family member at the time who thought that she was faking this illness because she seemed okay with the medication. But as it wore off, she would lose her. She would actually fall forward. Okay, and that's not an easy thing to do, fall forward.
Right.
But really, I remember thinking that this family member didn't understand this disease process.
And that can be common, and that's why education is so important, not only for the family, but actually for the person experiencing that. It can be frustrating when you have to plan your day and you'll have 2 hours where things aren't going as smooth as you'd like, and certainly healthcare professionals, but that's not uncommon.
Not uncommon. The other thing that sometimes we wonder about, if someone, you mentioned somebody who had an issue with perhaps maybe needing to write or something, okay? And maybe the medication might be increased at certain times a day for that, okay? We're going to be winding down very shortly. And I see you brought some literature there, and we will have a resource list at the end of the program for everybody. And I am so grateful for you to be able to come today and share this information. It sounds like there's so much more going on now to help these elders, these people who have the disease process, and their families. And there's so much more that we can be talking about. People sometimes are curious, like Fox with his, and then the Pope had his, and very different personalities, very different people, very different ages. Okay? So again, there's a lot of literature out there, and we will have that. What would you like to sign off with? What do you think?
Well, first, thanking you for giving me this opportunity to bring awareness. We do have, as you mentioned, an information referral center with the American Parkinson Disease Association, which is available for all individuals or families or healthcare providers. We have a telephone helpline, and
so the helpline goes on our resources.
Okay. And we work with 47 support groups in Massachusetts designed for people with Parkinson's, and do a lot of nice programs. So thank you so much.
And thank you so much for coming. Thank you for watching the program today, and I certainly hope it's been helpful. Certainly been a lot of information to take in, but important information and signs of hope out there with so much more research going on and so many more treatments being available. Thank you again. Bye now.
You're watching Channel 22.